Okay, thanks. Yeah, so in the end, we will talk a bit about the diagnosis of coagulopathy. So the conflicts of interest did not change in the last minutes. So I'm still a medical, I hope so, still a medical director of TEM International. And when we are talking about what's the reason for bleeding, sometimes it's quite easy. I always say when the blood comes up to the face of the surgeon, it must be a surgical bleeding from a high pressure area. But that is usually not the big issue, so we can identify that. You can make a suture. You don't need plasma or factor concentrates. I think the bigger issue is on the right side. We call the blood on floor syndrome. And then I think we have always to work quite closely together, surgeons, anesthetists, to solve this problem as quick as possible. One big issue with the standard lab is not only, as we heard, that it's not really designed to answer this question, it's also usually a long turnaround time. And that's a quite new study from Maastricht in the Netherlands. I was quite impressed how quick they get standard lab, because I think that's not everywhere in the same time here, so that they get emergency platelet count within 13 minutes in mean and emergency fibrinogen level with less than 40 minutes. So my experience usually is about 1 hour. But if you use point of care testing, you also get these results usually quicker. And in particular, also here in this study, they used a ROTEM with the A5 values. So when you do it point of care, you can get it in about 10 to 12 minutes. That was also shown already, so we have not to focus on this. It's just that the evidence for standard lab is also quite low. But as they mention here, the authors, old and even bad habits die hard. So it's not so easy to convince everybody that maybe PT-PTT is not really the best thing to guide therapy or to identify really which patient is at high risk. That doesn't mean that viscoelastic testing answers all the questions. We heard about limitations like a von Willebrand factor. We don't see that. You need some additional testing for the platelets. You don't see vasoconstriction. Even for me, the most interesting organ of hemostasis are endothelial cells. We have also not inside here, so they can change from anticoagulative to procoagulative behavior, in particular when we think, for example, on sepsis. So also very important and very interesting. You can, in principle, put in endothelial cells in the test system, but that are usually not the cells from the patient. So it's just interesting for some scientific work, but will not help you really for guiding therapy in one patient. Just to give you a short idea and how we work in this situation. So you have independent, if you're working with a TAC or ROTEM, you have some key parameters. One is so-called coagulation or clotting time, or the R time in the TAC. Starting the test by recalcification and then taking the time until you see the first clot. So that's a little bit similar like PT-PTT, but it's not the same, because here we are working with whole blood. In standard tests we are working with plasma. So of course it has also something to do with the enzymatic factors, with anticoagulation factors. But, and that it was for me more and more important at the ICU, for example, also shows tissue factor expression on circulating monocytes. So that, of course, you cannot see with plasmatic tests, but we see these more and more. If you have patients on assist devices, on bypass more than 2 hours, if they're cirrhotic patients, if they have infection, then the monocyte starts to express tissue factor, which for me is the first step when the patient goes to DIC, because then coagulation is not anymore localized at the site of injury. Thrombin generation can start everywhere where these cells are. Then, as also Marco already mentioned, clotting time might even be not so important. Clot firmness has a much better correlation to bleeding, but also to thrombosis. So we are again a little bit, we discussed in a session earlier about the therapeutic window. Maybe we even not only for platelet function, also for clot firmness have something like a therapeutic window that we know, okay, we have to go to a certain level to stop bleeding, but we should not overtreat the patient, which might also be associated with thromboembolic complication rates. mainly based on here platelets, fibrinogen factor 13. We know colloids have an effect, and as mentioned, we don't wait anymore for the maximum clot willingness, which also takes about 20 minutes. We more and more use the amplitude 5 minutes after clotting time or 10 minutes after clotting time. The only country you have to wait until 10 minutes is the US, because there you have to approval for each parameter. So the only country in the world where A5 is not approved is the US actually. And then we see if a clot is stable over the time or we have some fibrolysis. Usually we combine different tests to get more information than just using one test. And also the systems comes more close and close together. That, for example, we have also now with the TAC, then called functional fibrinogen, or also tissue factor activation in the rapid TAC. It's not exactly the same, but coming closer together. So just to give you an idea about the test you can use, which does not mean you have to use always all the tests. It depends on your question. So I prefer first to think what is your question and then use the test which may answer your question. So the so-called XTEM test, this is activated by recalcification because we always use citrated blood, then a tissue factor, and has an heparin inhibitor inside, polybrain, that you can use the test already during bypass. Why we don't use heparinase in this test? The clotting time in the XTEM test, usually 40 to 80 seconds, is too short that heparinase can eliminate this effect within this short time. Therefore, polybrain is like protamine, inactivates it immediately, but it's limited to amount. So if you have more than 5 units of heparin per milliliter, then you would have a residual effect. The second test is the so-called FIBTEM test. You see it's much smaller because we inhibit the platelets here with citrullin D. So by combining both tests, you get an idea if clot firmness is reduced. Is that mainly based on low platelet count or a fibrinogen deficiency or fibrinogen polymerization problem? And there's the third extrinsically activated test. That's the UPTEM test. In the beginning, it had a protein inside. We just changed to tranexamic acid. It's just because a lot of colleagues asked for that. We would have the substance inside, which is mainly used. The results are exactly the same. And it's, to be honest, it's also cheaper to use tranexamic acid in the test system. Then you have intrinsically activated tests. We don't use kaolin, it's ellagic acid, and you have here just a flat line because that is a blood sample collected during bypass. And then, of course, in the INTEM, there's no heparin inhibitor inside. You will get a flat line. Of course, you don't have to do it at that time. It's just to demonstrate. And then we have the so-called HEPTEM test with heparinase inside, so it's more after weaning from bypass to see is there a residual heparin effect or is there even a protamine overdose. And finally, we discussed in the last session the so-called ECATEM, so an heparin-based test. Primarily, it was developed for patients where we run bypass with Herodine. That's not often done, but now more and more patients at the ICU managed with direct thrombin inhibitors like agatoban or bivalirudin, and also now for dabigatran and maybe in the future other direct thrombin inhibitors. That's an algorithm we used. In the last years, we tried to simplify this a little bit. You know, when you have in mind our first studies, it was very complex. So we tried to minimize this. Even Kevin Kakupi minimized it a little bit more. He eliminated, for example, INTEM and HEPTEM. We had a long discussion if we should do that or not. But of course, you can always adapt the algorithm to the needs. There are some principal points of the algorithm, and the most important for me is that at the beginning of the algorithm, we should look at the clinical situation. So, for example, if there's no bleeding, we should not treat numbers. So that's the first step, and that is very important, that not by implementing point of care, you just increase everything, because if you see, as we mentioned, for example, after weaning from bypass, a reduced platelet function, which is nearly always reduced, but there's no bleeding, then of course, from my point of view, is no need for platelet transfusion. Also no need for fibrinogen or other things. But also for me, the sequence of intervention is important, because we also want to identify what's the most important reason and what is the most safe version to treat these patients. Okay, if we have significant bleeding, we just go step by step here, and if this condition, for example, is true, then on the right side is the, from our point of view, corresponding intervention. Of course, in patients with cardiac surgery, hyperthrombolysis is an issue. That doesn't mean that you don't have to give a prophylaxis. We'll go into details later on. Then, of course, after weaning from bypass, first we have to check if there is a residual heparin effect. Then we look at clot firmness, and if we identify a low fibrinogen, we even try to calculate the amount which we should substitute to come from a certain level to our targeted level. Then we look at thrombin generation, and that for me is important from the sequence, because from our experience, clot firmness is more important first. If there's no fibrinogen, we know that also prolongs clotting time, so it would not be the right intervention to treat clotting time first, even if you get it earlier. And from our experience, to increase thrombin generation might have a higher risk of thrombosis. And if there's continuous bleeding, we start the algorithm again, of course, with a new blood sample. Going a little bit more into details is that here what we try to see and published last year is that we not always have to wait for that we really see a breakdown of the clot. So we analyzed here for the identification of patients who finally have a thrombolysis, that we could see that if the clot is very weak in the beginning, we even can predict with the A5 or A10 value in Extrinsic 70 to 90% of the patients who will have thrombolysis later on. So that just makes the decision earlier, and of course, it's not good if you have bleeding, you have to wait, for example, 45 minutes to identify a late lysis. But again, that doesn't mean that I advocate against a prophylactic use. It's just in case when some centers say, okay, we don't want to treat everybody with an antithrombolytic drug, how you can then optimize your management from a diagnostic point of view. The next step, of course, important in cardiovascular surgery is heparin protamine management. And that is quite easy with the INTEM and the HEPTEM test. And there are in between some studies showing that this even can reduce transfusion requirements, because ACT is not very specific. It just tells you there's an issue with thrombin generation, but it's not that it's always is heparin. It can also an overdose of protamine result in a higher ACT, and of course also a deficiency of enzymatic factors. So that's a typical situation here with an INTEM. Clotting time is severely prolonged, should not be longer than 240 seconds, is more than 600. Also, clot firmness increases very slowly, but the question is that heparin or is that factor deficiency? And what we see here is in the HEPTEM test, it's nearly normalized. To be honest, not cardiac surgery, is a 6-month girl, liver transplant just after a perfusion. Nobody give this child heparin. That's just endogenous liberation of heparinoids from a liver graft. But you can see a similar situation in cardiac surgery. And that, of course, in cardiac surgery, we would treat it with more protamine, and liver transplant, usually we would just wait 10 minutes and it disappears. So again, I think algorithms are quite setting specific, and we have to adapt it to these needs. Then, if that is not true, we come to the next step, that clot firmness in the extrinsically activated test and in the FIBTEM are low. We have here two numbers because we have something like a stepwise approach. First, we go to this level, but in some cases, from my experience in particular in big aortic surgery, we sometimes need higher levels of fibrinogen. So then we have a stepwise approach that we not always go to the high level, only if the low level is not sufficient that we can go to a higher level. And what we use more and more is to calculate the amount. So for example, if we want to go from 8 to 12, that means an increase of 4 millimeters, then we need about 25 milligrams per kilogram, or about 2 grams of fibrinogen, or a pack of 10 of cryo. As we heard, of course, cryo is not so standardized, so reproducibility with cryo is more difficult than with fibrinogen. But even it gives you a certain amount that you know. For example, if you want to increase 8 millimeters, you can never reach this target with a pack of 10 of cryo. That's not possible in an adult. There are already old data from 2008 showing that in cardiovascular surgery, FibTem here in this study was the best predictor for blood loss and transfusion. So here again, if FibTem was below 8 millimeter, the best predictor. That's just one case from our hospital. What you see on the left side is just after weaning from bypass. Young lady, 85 years old, with bypass and aortic replacement. So when we look through the graph here, we see, for example, that clotting time in INTEM and HepTem is nearly the same, so no need for additional protamine. But we see that a clot firmness is here below our cutoff for A5 of 30 millimeters, 22. The FibTem is only 2 millimeters, that's significantly below 9. Our target was to go about 10, so that means 8 millimeter increase. That's about 50 milligrams per kilogram body weight. That would be 4 grams of fibrinogen concentrate, or 20 units of cryo, or for the same effect, not for the same amount of fibrinogen, 3 liters of plasma. According to my experience, the right ventricle will not be very happy about these 3 liters. And then, of course, also hemoglobin level goes from 8 to below 5. You give in additional red blood cells, not because of bleeding. And then, again, you have more transfusion-associated circulatory overload and, yeah, a lot of problems. So by managing this here with fibrinogen concentrate, you come not exactly to 10 millimeter, only to 9 millimeters, but we could extubate this lady 45 minutes later, and we can do this management within about half an hour, diagnostic therapy and control therapy. If that is not true, we look at the next step. So A5 in XTEM is below 30, but FibTem is fine, and it's also reasonable, if available, look at platelet function too. So that, I think, is an advantage of impedance agometry, that you also get it very quickly. So within about run time is 6 minutes. So you can even use it intraoperatively because data are quickly available. And that would be a reason then, of course, to give platelets. That's an example also, again, here from liver transplant, where we tolerate quite low platelets, so it's only 22,000 platelets. But you see fibrinogen in this case is quite high. So MCF here is 19, that would be A5 is about 16. And the clot firmness, it's not normal, but it's not so low as you might expect with a low platelet count. So we look less and less at the count. We look more what is the result of functional testing. And that's about 50,000 platelets, again, with a high fibrinogen. So there are some ways to compensate low platelet counts, fibrinogen, as also mentioned for the factors, factor 8, vitamin K dependent factors. There's a possibility to compensate. The question is that really reliable? And there's an interesting study in the British Journal of Hematology coming from New York. And they looked at the different patient population that were pediatric patients with immune thrombocytopenia. And the question of this study was, is platelet count or clot firmness the better predictor for bleeding? And the answer was clot firmness is better. So you see here these examples, it was always platelet count about 15,000. If A10 in XM was higher than 35, no bleeding. If it's between 35 and 25, mild bleeding, is below 25, severe bleeding. Unfortunately, in this study, they didn't use the FibTem, so we don't know, is that compensation by higher fibrinogen level or something else? But the answer was clearly that the clot firmness give you more information than just having the numbers of the platelet count. So we discussed already about platelets, so I will just shortly go over this. That's just some results we have with the ROTEM platelet device, just to show the difference here with the arachidonic acid stimulation, ADP and TRAP. That's just a healthy volunteer, aspirin, clopidogrel, and the reason why we don't see it in the standard viscoelastic testing, of course, thrombin is working the same level. Yeah, that's a new drug, PAR1 inhibitor, and of course, if everything is down, can be a GP2B3 receptor antagonist, a very long bypass time, or a severe thrombocytopenia. Also some results here from the platelet quite close results what we see in the multiplate. Of course, not the same numbers, because also the units are not the same. But also here a cutoff value of about 36 to discriminate between bleeders and less bleeders. But for me, very important here is, as mentioned before, it's not only that one pathway is inhibited, I think it's more important how many pathways are impaired, and that has a significant effect on bleeding. We also discussed a little bit about is there a need for PCC or thrombin generation. That's also just one case shortly. Clot defermers is fine here. When you look at clotting time in INTEM and HEPTEM, it's significantly longer in HEPTEM, which usually shows already a protamine overdose. When we look at ACT, that's prolonged. That was the reason why the colleague first gave more protamine, which was, I think, not really the best option. That we get later on. What we see here, clotting time is higher than 80 seconds, which usually reflects that clot formation is below 30% of normal, which was also then reflected by INR and TWIC. So here we targeted about 50%, giving 2,000 units of PCC. Alternatively, again, a huge amount of fresh frozen plasma. And you see ACT, INR, quick value, and also clotting time was corrected without any more protamine, just by increasing thrombin generation here with PCC. Yeah, it's just a study out also this year showing that that works quite well with XTEM. It works not so well with the kaolin tech, of course, because it activates the wrong pathway, if there is a pathway like this, because for the vitamin K dependent factors, we need the extrinsic activation starting with factor 7 and not with factor 12. And then finally, I think I'm coming just back for the last slides, for the therapeutic window, I think we can use more and more viscoelastic testing, not only for bleeding, also for predicting thrombosis or risk of thrombosis. That's one study in cardiovascular, showing in particular again for the clot firmness, if clot firmness in XTEM or INTEM is higher than 68 with a sensitivity and specificity of 94%, we predict thrombosis. And that is just shown also from New York, from Columbia University in non-cardiac surgery with the same cutoff values, that there is a quite good prediction of thrombosis. That does not tell us already what to do. Does it mean increase low molecular weight heparin, do something else, give antiplatelet drugs? First, it just gives you the information the patient is at risk. In other studies, we will have to see what is the right strategy to optimize this management. FIPTEM is not very good predictor. Here it was a weak predictor. In the other study from New York, it was not a predictor at all. So it seems to be that fibrinogen has not a very high risk of increasing risk of thrombosis, if not overall clot firmness is increased. Okay. So I think we stop at this time, and we can do all the other things in the discussion.